Good morning. I'll be talking about the ventilatory strategy in COPD and asthma. We know obstructive airway disease patients present a unique challenge if we have to ventilate them. So I'll start with a clinical case. An 84-year-old male presented to our emergency with complaints of fever, cough with expectoration, breathing difficulty, and drowsiness. The patient was a known hypertensive diabetic COPD and was smoking almost a pack of cigarettes for more than 40 years. He was tachypneic with borderline hypertension and was desaturating with a saturation of 81%. His chest showed bilateral reduced air entries with wheeze, and ABG showed an acidotic pH with a PO2 of 49 millimeter mercury and a CO2 as high as 103 millimeter mercury, and with a bicarbonate of 37. His 2D echo showed RA-RV dilated, moderate TR, and the pulmonary artery systolic pressure was 65 millimeter mercury. The LVEF was normal. And this was the X-ray of this patient. You can see bilateral hyperinflated lung fields, typical emphysematous picture with flattening of the diaphragm. So when we look at these kind of obstructive airway patients, studies have shown that the factors that affect hospital mortality include the length of stay before ICU admission. So the odds for hospital mortality in obstructive airway patients increase by 2% per day in hospital before they come to the ICU. The multi-organ failure and sepsis is itself a risk factor for increased hospital mortality. And acutely deranged arterial blood gas values like highly abnormal PaCO2 and PO2 are not useful for determining outcome. And acute exacerbation of COPD without X-ray changes in absence of a heart failure, pneumonia, or ARDS suggest a better prognosis, which means that if there is associated heart failure or a pneumonia causing acute exacerbation or an ARDS, the prognosis is poor. Now, looking at the factors affecting mortality in COPD patients, pre-exacerbation FEV1 has limited value in predicting outcome. In fact, a multidimensional evaluation including body mass index, airway obstruction, patient self-reported dyspnea, and exercise tolerance are found to be useful to determine outcome of patients who would receive invasive mechanical ventilation. Home use of long-term oxygen therapy does not definitely predict a poor outcome. Chronic hypercapnia and home ventilation requirement also do not necessarily predict a poor outcome. Previous use of invasive mechanical ventilation for acute exacerbation of COPD also does not appear to be an adverse prognostic factor. Age is not a reliable independent predictor for survival. However, body composition and nutritional status are independent predictors of survival. Presence of comorbidities are negative prognostic factors and include cardiovascular and diabetes as such. And the next important question that comes to mind is, what are the important issues in COPD and asthma? Why are we so much afraid to intubate and ventilate these patients? It's because of the dynamic hyperinflation. That is one very, very big problem. And what dynamic hyperinflation means is there is increased relaxation volume of respiratory system at the end of a tidal exhalation. Now, simplistically speaking, after the end of a tidal exhalation, the lungs empty to the functional residual capacity. If you are using a PEEP of, say, 5, then lungs will empty to a end expiratory pressure of 5, and the volume would be limited to FRC plus volume related to a baseline PEEP of 5. But here in dynamic hyperinflation, the end expiratory volume is much higher because of the retained air. And this increases exponentially if there is a dynamic hyperinflation, which is very common in severe acute asthma. So let me explain further. In healthy subjects, the end expiratory alveolar and airway pressures are 0 relative to the atmosphere. Suppose In you and me, there is no PEEP or CPAP. So the end expiratory alveolar and airway pressure are 0. And pleural pressure is negative at the end of exhalation. However, in these patients of obstructive airway disease, when they have dynamic hyperinflation, the alveolar pressure will remain positive throughout expiration, and that leads to development of auto PEEP, which is also termed as intrinsic PEEP or IPEEP. Essentially, that means that within the stipulated expiratory time, the lungs are not able to empty completely by the end of exhalation. So there is significant amount of air retained in the lungs at the end of exhalation, leading to intrinsic PEEP. Now here, this cartoon illustrates, now here the bottom figure that you see is this is the inspiration, a tidal volume, this is the lung volume and over time. And inspiration, this is the peak inspiratory pressure, then exhalation, end expiratory pressure. So this is the end inspiratory volume, this is the end expiratory volume. In this case, there is no CPAP applied, so it is pressure at the end exhalation is 0. It remains so with every breath. However, when there is dynamic hyperinflation, as is seen in the chronic obstructive airway patients, you see that the lungs are not coming to the baseline. They are not emptying to the baseline. End expiratory volume is higher. And this is also the extent of auto PEEP. And in situations of dynamic hyperinflation, the volume of end expiratory air continues to rise until the gas can hardly move into the alveoli. And this is called the volume trapped because of dynamic hyperinflation. And this will lead to significant intrinsic PEEP also. So this is a classical scenario in an exacerbation patient. And the same you can see in these graphics. This is a pressure time scaler. And as you can see, it indicates that this is a volume controlled breath. And you can see this is normal. So this is a normal pressure time scaler with a pause. This is peak pressure. This is plateau pressure. The difference is the trans airway pressure. And here you can see this is the inspiratory flow. This is the expiratory flow. It's reaching all the way to the baseline. Whereas here, as you can see, the lung is not emptying. And inhalation starts way before the lung has this expiratory curve has reached the baseline, indicating presence of intrinsic PEEP. Now, how do we know this extent? What are the guiding principles here? So two important things can be done because it will be difficult to calculate the end expiratory volume that is remaining in the lung, which actually, so what is the surrogate? We can do inspiratory hold, and we can look at the plateau pressure, and we can guide our therapy based on the plateau pressure that we are measuring. So we want to keep the plateau pressure less than 30 centimeters of water to reduce the complications. So that is an indirect way of looking at it. I'll explain it further. Now, why does intrinsic PEEP occur? So you can see this above cartoon. This is indicating this is end of inspiration. So you can see the alveoli are inflated to a pressure of 20 centimeters of water. And when the lungs empty completely, they are emptying to a pressure of 0 centimeter of water, indicating that there is no PEEP applied even in this case also. But the lungs are fully empty, as you can see. Whereas if the airflow is obstructed, as you can see here, the pressure inside the alveoli are also higher. As you can see, 35 centimeters of water, and the lungs cannot empty completely within the same expiratory time. So there is significant positive pressure remaining in the air, in the alveoli at the end of exhalation. So in this case, it is 15 centimeters of water. So this is also contributing to intrinsic PEEP. And when you do an expiratory hold maneuver, then you can see that what is the pressure here. So in case there is some external PEEP applied here, suppose it was 5 centimeters of PEEP here, then the lung would have emptied to an alveolar pressure of 5. And here this would have been 20. So the total PEEP would be 20 when you apply, and 20 minus the applied PEEP, that is 5, would give you the intrinsic PEEP. So coming back to the problem with COPD, intrinsic PEEP is caused by expiratory flow limitation because of significantly decreased elastic lung recoil because of emphysema. The lungs are already expanded. that leads to small airway collapse that further increases the airway resistance. And this whole problem is increased because of the short expiratory time. And because if the expiratory time is short, then there is a increase in the respiratory rate to an increase in the tidal volume to exhale out the volume and empty out the lungs. So this is a natural phenomenon. Now, what are the consequences of dynamic hyperinflation in passively ventilated patients, those who are on controlled ventilation, not breathing? They do not have spontaneous breathing. The mechanical power of the breath increases significantly, exposing the patient to development of barotrauma and hemodynamic compromise. These days we talk about ergotrauma or the mechanical power. Now, what it means is it is sum total of all the forces that are being applied to during the inflation of the alveoli. So this will depend on the plateau pressure, on the PEEP, driving pressure, and also will depend on the tidal volume, the respiratory frequency, and the inspiratory flow. So they all will contribute to the development of stress and strain because of the higher mechanical power. So that is the problem here, because all the pressures are high and inspiratory flows are increased. There is tachypnea, so that all leads to the lung is at a disadvantage. If the patient is actively breathing, that means he's spontaneously breathing, then the patient has to overcome significant intrinsic PEEP. So patient has to initiate inspiratory flows or use forceful inspiration to overcome the intrinsic PEEP, which means the inspiratory effort is significantly high. So significant amount of energy is being spent on triggering because there is a disadvantage, as I will show you, because of the intrinsic PEEP. The trigger has to be much higher by the patient. And this increased effort may fail to trigger the ventilator, oftentimes leading to ineffective triggering, which is the most frequent dysynchrony. We'll learn it in a graphic soon. So this is a very important cartoon. So please pay attention to this. Now, this is the volume pressure diagram relationship, as you can see. And this is a normal FRC. So normal FRC means if the lungs empty, the amount of air remaining in the lungs after a normal tidal exhalation is called functional residual capacity. In this case, you can see this is the baseline 0, and a pressure trigger of -2 is there. That means patient has to cause a negative deflection, negative pleural pressure of 2 centimeter to activate the ventilator in case the patient is breathing spontaneously. So this is the trigger. So you can see this is the trigger, -2. And this is the point where the volume starts increasing. So lungs have emptied to this point. This is the FRC. And they have increased. The lung is inflated to this level. So this is the end expiratory lung volume. And the expansion from baseline to the end inspiratory lung volume is the tidal volume. Say in this example, it is 500 ml. Now, consider a situation where the airway pressures are high, there is dynamic hyperinflation, and there is intrinsic PEEP. So you can see that the PEEP is significantly increased. There is intrinsic PEEP of almost 7 centimeter of water here. And the intrinsic PEEP, because now the patient is breathing from this point and he has to cause a dip of 2 centimeter below the baseline. For the ventilator, this continues to remain the baseline. So he has to generate a negative deflection of 9 centimeter of water, which is very, very high. So if he's generating 5, 6, these attempts of triggering are going to be missed and will not lead to, so that is what we call as ineffective triggering. And the work of breathing is very, very high. So the end expiratory lung volume is accordingly also very high because of hyperinflation. And please understand, in severe acute asthma, this will keep on increasing until the lung cannot accommodate any more volume. And when the lung is overdistended, the pressures are high, then we know that there is risk of barotrauma, there is risk of additional stress and strain. So that is the problem. All the pressures have gone up, and inspiratory lung volume has also gone up. If assuming the same volume can be accommodated, and the end expiratory tidal volume is significantly gone up. So what is the difference in terms of the alveolar distribution? If you see the functional units in COPD is a mix of low ventilation perfusion regions, high ventilation perfusion regions, and mixed patterns. There is small amount of shunt, generally less than 10% of cardiac output. As a result, there is increased in barotrauma and adverse hemodynamic consequences. Asthma, on the other hand, the hypoxemia is because of presence of generalized low ventilation perfusion units. And this hypoxia is generally countered. The body's compensatory mechanism is hypoxic pulmonary vasoconstriction, which causes redistribution of the blood flow. And once that is exhausted, there is a problem. Any increase in airway resistance due to bronchospasm, airway inflammation, or mucus obstruction will lead to significant reduction in expiratory flow, and there will be resultant dynamic hyperinflation. That is why in asthmatics, we want to put as large bore a tube as the patient's trachea can accommodate and keep the trachea absolutely free of any secretions. Another important thing is the hypercapnia is mainly due to increased dead space ventilation caused by alveolar overdistension. So when the alveolar air, the air cannot enter inside the alveoli, it is only the dead space that is being ventilated. So that we need to understand. Now, what is the impact? How does the heart react to this? So you can see that COPD, generally we see pulmonary hypertension, pulmonary vascular resistance is increased, there is dilatation of right side of the heart. In fact, right ventricular hypertrophy may be seen in chronic patients. And eventually, the LV function may also be impaired. And these changes are a result of dynamic hyperinflation, persistent dynamic hyperinflation, or chronic dynamic hyperinflation situations, and large swings in negative intrathoracic pressure, because the respiratory muscles have to overcome the intrinsic PEEP and the increased airway resistance. Now, how do we understand on a ventilator that patient has obstruction? So you can see this is a flow time scaler, and the shape indicates that this is a volume controlled breath because it's a fixed flow and constant flow. And you can see the blue is the normal. So the peak expiratory flow rate is less. The time required for complete emptying of the lung is more. Expiratory time required is more. And on the other hand, so this is, suggesting an expiratory obstruction. Whereas if the peak expiratory flow rate is very high, increased than normal, and the expiratory time is also short, it indicates that patient is actively expiring, spending energy, because we know it's a passive process otherwise. So here also you can see this as a volume trap. The dotted line indicates a normal expiration. So here you find that the flow has not reached the baseline. The inspiration has started here. So this is indicating the intrinsic PEEP. And if we calculate the volume, this will be the volume of air trapped in addition to the FRC at the end of exhalation. And active exhalation, you can see here also as in a volume time scaler, it doesn't reach the baseline, it goes below the baseline. And airway increase, you can see in this classical pressure time scaler of volume control ventilation, where a pause has been applied. So this is normal. You can see a peak inspiratory pressure. And once the pause is there, pause means both the valves are closed, there is no airflow. And it drops to the pressure in the alveoli because the inspiratory resistance is gone. So this is P-plat. The difference is the trans airway pressure. And in if the resistance is high, as is seen in the obstructive airway disease, you find the trans airway pressure increases significantly. The plateau pressure may remain same. So this is something that we can pick up from the graphics. When we look at the response to bronchodilator, again, you can see that the scale is, the flow time scaler shows normalization and increase in the peak expiratory flow rate and reduction in the exhalation timings. Another problem is, like I said, because the baseline pressure is high, the end exhalation volume is high, besides the end exhalation pressure due to intrinsic PEEP. So the overall pressures achieved, upper pressures achieved, and inspiratory pressure achieved are much higher, leading to a problem called overdistension. As you can see, the patient's alveoli are distended to this region, where there is only increase in the pressure and there is no resultant increase in the volume. So as a result, it suggests that we have to reduce the tidal volume. Air trapping can also be seen. This is how we pick it up on a flow volume loop. So you can see the brown line is normal and this red line is the abnormal one. It is not reaching the baseline. This is showing the extent of the intrinsic PEEP. And also we can see by the change in the expiratory part of the flow volume loop. So you can see that the peak expiratory flow rate is significantly less, and there is a scooped out pattern that you see here because of the decreased PEFR, and there is obstruction here, increased because of increased airway resistance. Now, one of the ways that has been suggested, suppose we want to measure how much volume is remaining because of DHLI at the end of exhalation. So this can be measured. So what is done is end inspired volume is measured, which is above the apneic FRC. So what is done is a period of 20 to 60 seconds apnea is given, and the total volume that is exhaled is measured. And this volume, end inspired volume will be the volume of gas at the end of inspiration above FRC, which is equal to the sum of tidal volume and volume at end exhalation above FRC. So both. However, this is difficult to perform. It's done in the research setting. So most commonly, we titrate our PEEP based on the plateau pressure. Now, this is a nice explanatory waveform cartoon, which shows us what is happening in the different areas of the, in relation to COPD. So you can see this is patient is breathing on a pressure support mode with a CPAP of 6 and a PSV of 8. And you can see there is dynamic hyperinflation. The measured intrinsic PEEP is about 8 centimeters of water. These arrows, this is a pressure time scaler. As you can see, airway pressure, and this is time. These arrows are indicating the ineffective triggers. So the ventilator rate, respiratory rate is 18 per minute, but if you look at these, it increases to 28 breaths per minute. Ineffective trigger because although patient is causing negative deflection of the negative pressure in the pleura by contracting the diaphragm, but this is not enough to overcome the intrinsic PEEP. You can see the flow time scaler, so you can appreciate the intrinsic PEEP here in the expiratory component. And when you look at the esophageal pressure, now you can see the ineffective triggers are more appreciated here. You can correlate with here. So you can see the deflections, which are not so apparent in the pressure time scaler. You can see. So this is ineffective trigger and the pressures are raised. So that means pleural pressures are high. If you look at the gastric pressures, now gastric pressures would be a reflection of the effort of the expiratory muscles during exhalation. So you find that gastric pressures are all positive. So that is also positive. It is also showing you the missed triggers, ineffective triggers. So you can appreciate in these two waveforms. And when you look at the diaphragmatic pressure, the diaphragm contraction, you find there is significant negative deflection. So significant negative deflection, suggesting that the mechanical power, the work of breathing is very high. The volume attained is much less, as you can appreciate here. So when we ventilate patients with obstructive airway disease, we need to understand that initially the primary goal is not to normalize the blood gases, but to prevent complications due to hyperinflation and intrinsic PEEP. And we need to maintain pH around 7.25 to 7.30 and not really bother about the normalizing the PCO2 values. So how to ventilate? Volume assist controlled ventilation is good. Why I say volume assist? Because your patient may start breathing. So then the volume assist will work. That is why you have to adjust the trigger right when you start your ventilation. When you adjust your ventilator initial settings, it gives you a square flow waveform. That is, flow is limited, which minimizes minute flow, the minute ventilation, because it cannot increase. The flow requirement cannot increase. So that is a safety point here. So further hyperinflation may be limited, and it allows sufficient time for exhalation. So this is better than the pressure control mode, where the flow is decelerating and flow may increase based on the patient demand, leading to significant increase in dynamic hyperinflation. So start with a low tidal volume, a low respiratory rate, and a constant inspiratory flow of 60 to 90 liters per minute. Adjust the IE ratio to 1:4 or maybe 1:5. Now, you need to measure the plateau pressure. This is very, very important, because you want to see where you are in terms of plateau pressure. If you are, say, 25 or 26, which is way below 28, then you can use increase the respiratory rate to improve the gas exchange or to adjust the pH. However, if you find you're already high, you are higher than 28 centimeter of water in terms of PEEP, then you need to further come down on the minute ventilation, which you can do by either reducing tidal volume or respiratory rate, or both, especially in patients who have intrinsic PEEP. So please understand, increasing the exhalation time but keeping the minute ventilation constant has a minimal effect on hyperinflation. So this strategy will not help. You have to come down on the minute ventilation and increase the expiratory time, then it works well. Increased expiration time, just making it 1:4, doing nothing for minute ventilation, is not going to make any change as far as hyperinflation is concerned. So we know we can apply PEEP in COPD patients. So what about PEEP? Post-intubation, if the patient is completely passive, that means he is not triggering the ventilator, and the problem is purely resistive, that the airway resistance is high, then, well, even zero PEEP would be optimal theoretically, because PEEP, any PEEP that we apply will, reduce the expiratory driving pressures and will increase the hyperinflation. So, but this is seldom seen in clinical practice. So 3 different possible effects of PEEP are seen in these hyperinflated COPD lungs. So patients who are like above, where there is pure expiratory flow limitation, there is no change in the degree of hyperinflation. So what is suggested is we can gradually increase the PEEP until we find to a level where the plateau pressure is not changing. But we should stop or decrease the PEEP applied if the PEEP starts rising. Any increase in PEEP increases the PEEP. Second effect that we can see is this will increase the PEEP and unexpiratory lung volume. That means we cannot apply. Or a paradoxical response may be seen, where the PEEP, when it is increased, it decreases the PEEP and expiratory lung volume. And this is generally seen in patients who have expiratory flow limitation and they have highly heterogeneous lungs. So how do we know? Well, we will know clinically. Again, we have to titrate PEEP based on the PEEP. The moment where PEEP is increasing, we should stop further increase in PEEP or come down on the PEEP. What if the patient is completely passive and has problem of pure expiratory flow limitation? Well, here, as I have told you before, the application of external PEEP does not change the hyperinflation or the total PEEP that patient is having until it approximates, the applied PEEP approximates 80% of the intrinsic PEEP. And once the patient can trigger the ventilator, that means he starts breathing, he becomes active, then moderate external PEEP can be applied to counterbalance the intrinsic PEEP and reduce the effort required to trigger the machine, which will also improve the patient ventilator synchrony. So we need to understand that patients with COPD are susceptible to ventilator-induced hyperinflation as well as dyssynchrony. The most common dyssynchrony is ineffective triggering. Now, because intrinsic PEEP increases the effort required to trigger the ventilator, any weak respiratory effort will fail to trigger it. That is ineffective triggering again. So ineffective triggering could be that you have made the trigger less sensitive. It is your problem, the setting problem, or you have applied a very high pressure support and the tidal volume is high and the pH is even higher, respiratory alkalosis. So you need to come down on your pressures. Do not attempt to adjust pressure support to a tidal volume of more than 6 ml per kg. 6 ml per kg is enough. So simple explanation, do not set pressure support level too high in these patients. Limit the tidal volume that is being delivered in PSV mode. That is the remedy for dynamic hyperinflation. You can decrease the insufflation time by decreasing the level of expiratory trigger. That means the cycling. So normally, it is preset to 25% of the peak flow. You can increase it to 40% or 50% also to give more time for exhalation and reduce dynamic hyperinflation. Now, looking at severe acute asthma, one of the things that we need to know is if we invasively ventilate these patients, the risk of complications and resulting significant mortality is significantly high. Post-intubation hypotension is very common because of major lung hyperinflation, hypovolemia, and sedation. So be prepared for this. Like I said earlier, put a bigger bore tube because the resistance is proportional to radius of the tube to the power 4. Intubation should be reserved, therefore, for patients who have life-threatening conditions like they are in respiratory arrest, having bradypnea, altered consciousness, patient is totally exhausted, and or there is severe or worsening hypercapnia, or there is major respiratory distress despite adequate medical treatment. Pulmonary hyperinflation in severe acute asthma may be extremely high because there is major increase in expiratory resistance due to airway obstruction, which is related to edema and bronchospasm. So what should be the strategy? Same. Minimize the hyperinflation by reducing the minute ventilation and increasing the exhalation time. That is low tidal volume, low respiratory rate, high inspiratory flow rate, targeting I ratio of 1:4 to 1:6. Do not apply a low level of external PEEP because application of PEEP in asthma remains controversial. So no PEEP in acute severe asthma. Degree of hyperinflation must be closely monitored using end inspiratory and expiratory holds with the aim of limiting the P-plat and obtaining the lowest possible intrinsic PEEP, total PEEP. Volume assist control mode is better with square wave flow. So volume modes and not pressure modes. When we decrease the minute ventilation, the PaCO2 might increase dramatically, but please understand the major aim is reduction in minute ventilation and dynamic hyperinflation and reducing the intrinsic PEEP. A reduction in PaCO2 is a secondary goal. So this is again illustration that this is how you can, adjust the ventilator in severe acute asthma. Now, two different kind of fatal patterns have been seen in fatal asthma where the patient dies. Now, type 1 and type 2. Now, type 2 is the deadly one where there is acute deterioration over hours. This is sudden asphyxia asthma. And fortunately, the frequency is 20% or less. And alveoli, bronchi are more or less empty. There is no mucus plugging here, but there is significant neutrophil inflammation. And they respond quite faster to the treatment. So they should be picked up. And these patients, if we can't, pick it up, they will die. Whereas the type 1, asthma would be subacute in nature. They will be slow onset and will be picked up later. Slow onset, late arrival. So you give less attention. Patient was doing well yesterday. The frequency, fortunately or unfortunately, is 80 to 85%. There is extensive mucus plugging and there is eosinophilic inflammation. Response to treatment is slow. However, we can prevent this. That is possible, whereas possibly acute deterioration in type 2 we cannot prevent. Now, this cartoon illustrates roughly the ventilatory strategy. Now, here the upper part shows patient management, where in acute respiratory failure in spontaneously breathing patients, we can use non-invasive ventilation to prevent intubation. There is level 1 indication for NIV in acute exacerbation of COPD. In Western world, in UK, it is also used as a ceiling therapy in the elderly, severely elderly with significant comorbid conditions, that they will not intubate and this will be the final therapy. A patient can be intubated whenever there is a need. If the condition is deteriorating on an IV, identify early and put them on volume assist control ventilation, lower tidal volume, prolonged expiratory time, moderate level of PEEP in COPD, no PEEP in asthma. Do not attempt to normalize the blood gases. And once they become active, that is their spontaneous activity returns, use pressure support, or you can continue on volume control assist ventilation. And you can apply in COPD moderate level of PEEP, basically to counter the intrinsic PEEP. And you should check them daily for readiness to wean. If that is the case, you can give a spontaneous breathing trial. And tracheostomy, I'll discuss. It's not so easy here. And use prophylactic NIV post-extubation in COPD patients. And you can also consider this high-flow nasal cannula or both. I'll talk about this. Newer modalities are HFNO and NIV sessions, helium-oxygen mixtures to improve NIV success, and use of Accord to remove carbon dioxide. And also, looking at the diaphragm ultrasound to detect the NIV failure, NAVA to make the trigger better. And so let me talk about weaning. We need to assess them daily, apply spontaneous breathing trial if they are fit to be weaned, either using T-tube or pressure support ventilation. Prophylactic post-extubation NIV decreases the acute respiratory failure following extubation and reintubation rate. So this is a very good high-level indication in COPD. HFNC is also found to be helpful. And in fact, the addition of NIV sessions to HFNC seems to be more efficient for preventing reintubation than HFNC alone. So large periods can be covered by NIV, but when there is visitors are coming, the patients can talk during eating, drinking, you can use HFNC. So this combination is found to be better. NIV hastens weaning in COPD patients who otherwise are repeatedly failing breathing trials. But having said that, 4 to 5% of patients would still require tracheostomy. Tracheostomy has per se no effect on the disease per se or the progress of the disease. Tracheostomy is only related to improvement in the comfort and long-term management of the patient. So this needs to be discussed with the family and with the other treating physicians as well. Long-term outcome, patients who were intubated and mechanically ventilated at least for 3 weeks, 1 to 2 years survival ranges from 40 to 50%. So when we have the same patient coming to again, we need to counsel the family about the expected survival. There was one longitudinal study which showed that patient who remained on prolonged mechanical ventilation and survived to discharge from the weaning facility, 54% could be completely extubated and weaned from the ventilator, whereas 30% were still attached to the ventilator at the time of discharge from the facility. And the survival differed in the two. Those who were extubated or removed from the ventilator, there was 1 year survival of 63%, whereas ventilator-dependent patients, it was 22%, 1/3. Again, survival was not found to be influenced by the cause of respiratory failure, even if it was COPD. We need to use lowest possible PEEP, and we need to use volume control mode with square waveform. As I have said, reduction in CO2 is secondary goal. And my final remarks are, mechanical ventilation is the cornerstone of management of life-threatening COPD and asthma. Invasive mechanical ventilation should be reserved for patients who are failing an IV, especially in COPD, and they are subsequently intubated. Main goal is to limit hyperinflation, reduce intrinsic PEEP by reducing minute ventilation, providing low tidal volumes and prolonged exhalation time. Normalization of blood gases is a secondary therapeutic goal, and a low level of external PEEP may be applied to patients who are actively breathing to counter the effect of intrinsic PEEP in COPD patients. The ventilatory strategy in asthma is almost similar, except NIV is not recommended because there is no evidence that it causes any benefit. And weaning, again, should be done as soon as they tolerate a spontaneous breathing trial. Selected patients, prophylactic post-extubation NIV may be used. However, it's not been found to be, there is no recommendation to this effect. We can use a high-flow nasal cannula, which is as effective as NIV to prevent reintubation. And tracheostomy, again, has to be a multidisciplinary issue. So, ladies and gentlemen, I've come to the end of my presentation, and we know that the COPD and asthma patients present a unique challenge, and they present a unique challenge, and it's a last resort when we have to intubate these patients. So do not try to normalize the blood gases. In fact, the strategy in these very, very severe COPD or asthma patients should be to minimize dynamic hyperinflation and reduce the degree of intrinsic PEEP, and less ventilation, increased expiratory time is the key. Thank you very much for watching. Thank you.